Hey, welcome back to Not So Complicated, and today we are continuing our second part of respiratory pathology, and we are doing USMLE Step 1 First Aid Study with Me series, and it's day 5, right? So let's go into the respiratory pathology, and I apologize for abrupt ending of our previous session. So let's go from the co-workers pneumoconiosis. Co-workers pneumoconiosis, there is actually prolonged coal dust exposure and then macrophages laden with carbon that lead to inflammation and fibrosis, right? And that is also called as black lung disease right here, and it also increases the risk of Kaplan syndrome. Kaplan syndrome is actually rheumatoid arthritis and pneumoconiosis with intrapulmonary nodules, as we have discussed earlier. And then here we have it affects upper lobe, right? And small rounded nodular opacities are seen on imaging. And in anthracosis, asymptomatic condition found in many urban dwellers exposed to sooty air, that is also seen in Coworkers pneumoconiosis. And in silicosis, obviously by name, there is something called silicosis, and it is associated with sandblasting, fundraise, and then mines, right? And macrophages respond to silica and release fibrogenic factors right here, leading to fibrosis. Silica release Macrophages release fibrogenic factors in response to silica. Actually, it is thought that silica may disrupt phagolysosomes and impair macrophages, increasing susceptibility to TB. That is what it occurs. So, if a person has a tuberculosis, then there is an increased risk of silicosis, and it also increased risk of cancer, carpulmonal, which is right ventricular hypertrophy, and then Kaplan syndrome, as we talked earlier. And their silicosis also affects upper lobes, and there is egg cell calcification of hilar lymph nodes on chest X-ray. This is very high yield, so you have to remember this egg cell calcification, and they are also like the silly egg sandwich, which I found is mine. The silly egg sandwich I found is mine, right? So mine workers, and that is found in sands, like sand is silica. There is silica in sand, right? And that has egg cell calcification. So the silly egg sandwich I found is mine. That is the mnemonics. This is very high yield, you have to remember this. And here it is, an image that we discussed earlier in berylliosis on histology, and therefore occasionally there is granulomatous, there is non-caseating granulomatous inflammation in here, right? So that is on berylliosis. Let's go into acute respiratory distress syndrome. Okay, acute respiratory distress syndrome, we will talk about its pathology, and then its causes, diagnosis, consequences, and management. Acute respiratory distress syndrome is actually there occurs alveolar insult, and that leads to the release of pro-inflammatory cytokines, and then it will release neutrophil recruitment, activation and release of toxic mediators like reactive oxygen species and proteases, right? And that will lead to capillary endothelial damage and increased vessel permeability. And since vessel permeability is increased, there is leakage of fluid. And the leakage of fluid due to increased vessel permeability is also called exudation. So this is a case of exudate, and leakage of protein-rich fluid into alveoli, and that will lead to the formation of intraalveolar haline membranes as shown in figure A right here. Intraatrial haline membrane, that is it. Intraalveolar haline membrane, the shaded portion that I did in here, that is it. And also non-cardiogenic pulmonary edema, normal PCWP, and that will lead to decrease in compliance and increase in BQ mismatch. Decrease in the BQ mismatch, that is ventilation perfusion mismatch, and that will lead to hypoxic vasoconstriction and increased vascular resistance. So there is also loss of surfactant, which contributes to alveolar collapse, as in preterm infants and in drowning cases that can happen. So that is the pathophysiology of acute respiratory distress syndrome. The causes are sepsis, which is the most common cause. Sepsis is actually the widespread infection spreading throughout our body through blood. That is sepsis. And there is stages of sepsis, the sepsis and then septic shock. Septic shock is a life-threatening condition, and also aspiration pneumonia, where something aspirate, like aspirates will fill the lungs, right? And then in burns cases, then in trauma case, pancreatitis case, and also drowning injuries, that is the acute respiratory distress syndrome causes. The diagnosis is usually due to diagnosis of exclusion with the following criteria is done, right? So ARDS, since it is a case of ARDS, the mnemonics is also ARDS. A for abnormal chest X-ray, which shows bilateral lung opacities, and R for respiratory failure within 1 week of alveolar insult. It normally has type 2 respiratory failure because there is both hypoxemia and hypercapnia. And D for decreased partial pressure of oxygen by fraction of inspired oxygen, that is ratio less than 300. The ratio should be more than 300 to be normal, but if there is less than 300 ratio, then it is a case of hypoxemia, and that hypoxemia is due to increased intrapulmonary shunting and diffusion, right? And then S for symptoms of respiratory failure, which are not due to heart failure or fluid overload. We have to remember like that. There are symptoms of respiratory failure, but they should not be due to heart failure or fluid overload. That is exclusion criteria right here. So diagnosis of ARDS is by ARDS, A for abnormal chest X-ray, which shows bilateral lung opacities, like in here you can see diffuse opacities right here, right? Even the border of heart is blurred in here, like this is a border of heart, but it is blurred, right? So the consequences of ARDS is impaired gas exchange, decreased lung compliance, which means the air cannot accumulate in our lungs as much as it needs to be. And then there is also pulmonary hypertension. We'll talk about pulmonary hypertension in vascular disease of respiratory system. And also in management, there is a treatment, there should be the treatment of underlying cause, like what is the cause of ARDS, right? Like sepsis, aspiration pneumonia, trauma, or pancreatitis. And also mechanical ventilation if there is decreased tidal volume and increased PEEP, which keeps alveoli open during expiration, right? Now we will go to the sleep apnea or obstructive sleep apnea. That is it, obstructive sleep apnea. It is the repeated cessation of breathing, right? So PEP, I will tell something about PEP to you. PEP is actually positive and expiratory pressure, and it is a pressure applied by the ventilator at the end of each breath to ensure that alveoli are not so prone to collapse. So it usually keeps alveoli open during expiration. That is PEP. So we should increase PEP, right? So basically, the sleep apnea is also called obstructive sleep apnea. There is a type of sleep apnea which is obstructive sleep apnea, right? And also central sleep apnea and obesity hyperventilation syndrome. It is also a type of sleep apnea, and it is also called Pickwickian syndrome. We'll talk about it later. Sleep apnea is the pathophysiology is repeated cessation of breathing for greater than 10 seconds during sleep, and it will cause to disrupted sleep and daytime somnolence. Somnolence is actually something called feeling sleepy. That is what somnolence is. And diagnosis is confirmed by sleep study, that is polysomnography, and nocturnal hypoxia can cause systemic and pulmonary hypertension, arrhythmias like atrial fibrillation and further, and also sudden death. So hypoxia leads to increase in erythropoietin release, so that will lead to increase in erythropoiesis. So basically in sleep apnea there is reflex polycythemia, right? We have to remember the concepts like this. And also the types, there is obstructive sleep apnea where respiratory effort against airway obstruction is done, like something is obstructing your airway. Like if you have a large tongue or a thick tongue, then that can obstruct your airway when you are sleeping. That is also a cause of obstructive sleep apnea, and that is also a cause of snoring actually. and the partial pressure of oxygen usually is normal in day. It is associated with obesity, loud snoring, and daytime sleepiness, usually caused by excessive parapharyngeal or oropharyngeal tissue in adults, and also adenotonsillar hypertrophy in children. That is the main cause, right? We have to remember this, like excess parapharyngeal and oropharyngeal tissue in adults and adenotonsillar hypertrophy in children. And the treatment should be weight loss, CPAP, and the dental devices, hypoglossal nerve stimulation, and also upper airway surgery. These all are the treatments. So in central sleep apnea, it is impaired respiratory effort is due to CNS injury or toxicity. It is in name, right? Central sleep apnea, and also there is CNS injury or toxicity, and also there is congestive heart failure that can cause that. So C for central sleep apnea, C for CNS injury or toxicity, and then C for congestive heart failure. And also opiates can lead to central sleep apnea, and it may be associated with Stokes respirations too. So C, 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 C. Stokes respiration is basically it is an oscillation between apnea and hyperapnea. Treatment is positive airway pressure. It's actually continuous positive airway pressure, that is CPAP in here, right here. Okay, that is the treatment of sleep apnea. And also Stokes breathing, and there is also other kind of abnormal breathing that is also called Biot's breathing. And oscillation between apnea and hyperapnea occurs due to underlying physiology. Since you imagine your breathing rate decreases, and then your peripheral chemoreceptors get excited and your breathing rates increases, but it doesn't increase to normal and increases more than normal, and that will lead to the depression of central nervous system, and that will lead to apnea again. So it is an oscillation between apnea and hyperapnea. So C for central sleep apnea, C for CNS injury, C for congestive heart failure, and C for Stokes breathing. You have to remember like this. And obesity hyperventilation syndrome, as I said earlier, it is also called Pickwickian syndrome. And in a patient with obesity, a BMI greater than 30 kg per meter square will lead to hyperventilation, and that will lead to increase in partial pressure of carbon dioxide during waking hours, that is retention, and also decrease in partial pressure of oxygen and increase in partial pressure of carbon dioxide during sleep. So treatment is weight loss and positive airway pressure. All of those treatment is like that. So that is how we complete our sleep apnea too. Let's go to the vascular diseases of pulmonary system or respiratory system, and we will tap into pulmonary hypertension at first. So what is hypertension? Hypertension is increased in blood pressure, but if it is in pulmonary region, that is pulmonary hypertension, and in pulmonary artery, the pressure should be greater than 20 mmHg at rest. That is called pulmonary hypertension. So you have to remember this specific pressure because this is very high yield. Elevated mean pulmonary arterial pressure should be greater than 20 mmHg at rest, and it results in arteriosclerosis, medial hypertrophy, intimal fibrosis of pulmonary arteries, and also plexiform lesions, right? So increase in pulmonary vascular resistance will lead to increase in right ventricular pressure that causes right ventricle hypertrophy, that is parasternal heave on examination, and also right ventricular failure. Obviously, since right ventricle has to pump the blood against the lungs, because it has to pump the blood to the lungs for oxygenation, and since there is resistance, arterial resistance in pulmonary vessels, it cannot pump the blood, and so the workload increases. Since the workload increases, that will cause to hypertrophy, right? So that is what it happens in pulmonary hypertension. And in etiologies of pulmonary hypertension, there is group 1, which is pulmonary arterial hypertension. So it is often idiopathic, and it is more in females than males. This is the statistics. This is the demography we have to remember, more in females than males. And it is also heritable PAH can be due to an inactivating mutation of BMPR2 gene. Which gene? BMPR2 gene. It can occur like that. Normally inhibits vascular smooth muscle proliferation. So if there is if there is the mutation in this inhibitor gene, then there is proliferation. Obviously that will lead to proliferation of vascular smooth muscle, will lead to increase in resistance, narrowing of the blood vessels, the lumen of blood vessel, and that is poor prognosis. That has very poor prognosis. And then pulmonary vasculature endothelial dysfunction results in increase in vasoconstrictors, that is example endothelin, and also decrease in vasodilators, example nitric oxide and prostacyclins, right? So the other causes include drugs, example amphetamines, cocaine, connective tissue disease, HIV infection, portal hypertension, congenital heart disease, and schistosomiasis. These are other causes. And in group 2 there is left heart disease. The causes include systolic or diastolic dysfunction and also valvular diseases. Group 3 is lung disease or hypoxia. So destruction of lung parenchyma, example in COPD or chronic obstructive pulmonary disease, and also lung inflammation or fibrosis like interstitial lung diseases or restrictive lung diseases. There is hypoxemic vasoconstriction. It's in obstructive sleep apnea and also living in high altitude, right? Hypoxemic vasoconstriction. So basically, actually what happens is in acute mountain sickness is that hypoxemic vasoconstriction that will lead to increased in hydrostatic pressure and also edema. So it occurs acute pulmonary edema in acute mountain sickness, right? That is an off note, that is a bonus point for you. And also there is a fourth group, that is chronic thromboembolic group, and it will lead to recurrent microthrombi that will decrease cross-sectional area of pulmonary vascular bed. Group 5 is multifactorial, which causes include hematologic systemic metabolic disorders along with compression of the pulmonary vasculature by a tumor. And physical findings in select lung diseases. Let's see the differences between these select lung diseases, like pleural effusion. Pleural effusion is actually the feeling of fluid in intrapleural space, right? And atelectasis is the collapse of lung. Simple pneumothorax is the hyperinflation of lungs. Tension pneumothorax is also a type of lungs, hyperinflation of lungs, where there is that is the one-way valve mechanism, or like that you have. We'll talk about it later. And there should be consolidation, as in lobar pneumonia or pulmonary edema. So pulmonary edema presents with pink frothy sputum if there is any cough like that. So pink frothy sputum is seen in pulmonary edema. Let's see, in pleural effusion, breath sounds are decreased because obviously the lungs are filled with fluid. So they are decreased in percussion. It is dull. Fremitus is also decreased. And tracheal deviation, there is none if it's small. And away from side of lesion if it is large. Away from side of lesion, because since it's like the volume of fluid increases in one lung, then that lung will obviously compress the other lung, right? So that is why tracheal deviation can occur. And in atelectasis, there is decrease with sounds because there is collapse of lungs and there is no viable lungs. There it is dull. Percussion is dull, and there is also decreased fremitus. And it will lead to tracheal deviation will be toward side of lesion because there is atelectasis, there is collapse of one lung. And since the lung has bronchi and bronchi is also a part of trachea, it will pull the trachea into its one direction because there is collapse. And since the parenchyma of lung is collapsing, not the pleura of lungs, the pleura is adhered to our chest wall. So basically the lungs cannot go towards the trachea has to go toward the lungs. That's why it is the tracheal deviation is due to toward size of lesion. And in simple pneumothorax, the breath sound is decreased. Percussion, there is hyperresonant because the ear is filled in lung spaces, and also in tension pneumothorax there is hyperresonant. Fremitus, both of them are decreased. And in simple pneumothorax there is non-deviation, and tension pneumothorax there is away from side of lesion deviation. And consolidation, bronchial breath sounds, light respiratory crackles, egophony, and whispered pectoriloquy are seen. Whispered pectoriloquy is actually something when you auscultate a person in the chest, then you hear his words clearly in the diaphragm of his stethoscope. Like he will talk from his mouth, but you will hear the specific words in your stethoscope. That is whispered pectoriloquy, right? So egophony is also a breath sound. It is a high pitch wheeze, that is egophony. And there is a dull in percussion, and also fremitus is increased in percussion. Fremitus is increased, and then there is no tracheal deviation. So what is digital claving actually? This digital claving is, as we talked earlier, there is hypertrophy of nail bed, right? So hypertrophy of nail bed, the test to diagnose whether there is claving or not is Samroth's test. We have to put the thumb, two sides, two hands thumbs in lateral position, and see if there is a diamond shaped space between them or not. So if there is no diamond shaped space, then it is a case of claving. And also increased angle between nail bed and nail bed, almost greater than 180 degrees. 180 degree is digital claving. So pathophysiology is not well understood, but in patients with intrapulmonary shunt platelets and megakaryocytes become lost in digital vasculatures, and that will lead to local release of PTGF. PTGF is platelet derived growth factor, and also vascular endothelial growth factor, and it can be hereditary or acquired. The causes include respiratory diseases like idiopathic pulmonary fibrosis, cystic fibrosis, bronchiectasis, lung cancer, and also cardiovascular diseases like cyanotic congenital heart disease, and also infections like lung abscess, and TB, and others like IVD, which is inflammatory bowel disease, and not typically associated with COPD or asthma. We have to remember this. So clogging is not typically associated with COPD and asthma. COPD includes bronchiectasis, bronchiolitis, emphysema. There is not any digital clogging actually, not always. And in atelectasis, as we talked about it earlier, it is a collapse of lung. Here you can see lung is collapsed, right? Atelectasis are different types of atelectasis are there: contraction atelectasis, and then rejection atelectasis. There are and compression atelectasis. There are different types of atelectasis. Alveolar collapse is there, right? Upper lobe collapse against mediastinum in figure A right here. There is right upper lobe collapse in here, right? So let's see. There are multiple causes. There can be obstructive cause, compressive cause, contraction cause, or adhesive cause. So obstructive cause, there is airway obstruction, prevents new air from reaching distal airways. So old air is reserved. Example, foreign body, mucus plug, or tumor can cause collapse, right? And then compressive, there is external compression on lung, decreases lung volumes. Example, space occupying lesion or pleural effusion. Okay, that is it, right? So external compression is there. In pleural effusion case, there is a fluid filled in the pleural space, intrapleural space, right? So when this amount of fluid increases, then it compresses this lung towards this side right here. So that is compressive collapse. And in contraction case, let's see if there is fibrosis. There is extensive fibrosis and scarring of lung parenchyma that distorts alveoli. That is how there is becoming contraction in here. So example is sarcoidosis. Classic example of contraction atelectasis is sarcoidosis. And in adhesive, there is due to lack of surfactant. Example in NRDS in premature infants. It can cause adhesive contraction or adhesive atelectasis or collapse of lungs, right? So it is decreased by incentive spirometry or increased positive end expiratory pressure than during mechanical ventilation. So that is how atelectasis is. Now we will tap into pleural effusions. So pleural effusion is actually the accumulation of fluid in lungs, as I talked earlier. The fluid can either be exudate or can be transited. There is a criteria that is used to distinguish whether it is an exudate or transited, and that is called Light's criteria, right? So Light's criteria is actually, you have to remember, you have to study this criteria in clinical science and medicine, internal medicine. Light's criteria is very important. So let's begin from the beginning. So excess accumulation of fluid is there between pleural layers. You can see there is excess accumulation of fluid. You can see between the pleural layers, right? These all things are fluids, and it leads to restricted lung expansion during inspiration. Obvious, it is very obvious, and it can be treated with thoracosynthesis or to remove, reduce, or fluid. Thoracosynthesis is actually needle aspiration, like draining this fluid out of the chest, and it is usually done from fourth to fifth intercostal space. That is thoracosynthesis, and based on Light's criteria, uh, fluid is consistent with an exudate if there is very specific criteria. If pleural fluid protein to serum protein ratio is greater than 5, and if pleural fluid LDH to serum LDH is greater than 6, or if pleural fluid LDH is greater than 2 to 3 times to a 3 times upper limit of normal serum LDH, then the fluid is exudate. Otherwise, the fluid is transited. That is actually the diagnostic feature in here. So in exudate, the difference between the features of exudates and transidates is that in exudate there is cloudy fluid, that is cellular, due to increased protein content, and in transitate there is clear fluid, that is hypocellular. And in exudate, this is usually due to infection like pneumonia, tuberculosis, malignancy, connective tissue disease, lymphatic obstruction like pseudothorax, and trauma. It often requires drainage due to increased risk of infection, and it is due to increase in hydrostatic pressure, as in heart failure, sodium retention, or due to decrease in oncotic pressure, it's nephrotic syndrome or cirrhosis. So it's basically in exudate there is loss of capillary membrane intact. So patency of capillary membrane is lost, and there are spaces between these capillary endothelial cells, and that will lead to the leakage of fluid causing exudate. But in transudate there is either an increase in hydrostatic pressure or decrease in oncotic pressure, and also lymphatic obstruction can occur. So in normal there is plasma proteins like this, but in exudate, fluid inflammatory cells and protein leakage occurs due to increased vascular permeability. And in transudate, there is increased hydrostatic pressure either, or there is decreased oncotic pressure, which will lead to fluid leakage, right? So this is pre-treatment, this is pre-treatment, this is post-treatment. These all fluids are drained out of the lungs, and the lungs are clear now. This is also post-treatment. Here you can see this amount of fluid in here, but that is all drained out by thoracosynthesis. You can see like this in transverse cross section. So let's go to the pneumothorax. There are type of pneumothorax, different types of pneumothorax. So we can talk about that. So pneumothorax is actually the accumulation of air in pleural space. So there is hyperinflation of lungs, right? There the classic features is due to, you can see here, there is air in pleural space. As you can see, there is air in pleural space, unlike the other side of these lungs. Right? There is no air, it is quite normal, but there is air in pleural space, which is pneumothorax. And the classic clinical features are dyspnea and uneven chest pain. And chest pain is actually pleuritic chest pain is there. Entire chest is act, and there is decreased tactile fremitus, hyperresonance due to air fluid, and also diminished with sounds on all affected side. So there are types of pneumothorax: primary spontaneous pneumothorax, secondary spontaneous pneumothorax, traumatic pneumothorax, and tension pneumothorax. So what is actually primary spontaneous pneumothorax? It is due to rupture of artificial subpleural valve. Rupture of apical subpleural valve or cyst, right? And it occurs most frequently in tall, thin, young males. Tall, thin, young males, and it is associated with smoking, tobacco smoking, and vaping. So that is why how you can remember. These days there are tall, thin, young males, right, who usually vape and vape and vape. So that causes subpleural valve. Subpleural valve is like that. This is a pleura. Imagine this is a pleura, and there are formation of subpleural valve. It is actually the complication of emphysema, since smoking there is a risk of smoking causes permanent dilatation of this alveoli, distal alveoli, and that causes emphysema. And if the emphysematous lung is too severe enough, then the subpleural blabber bubble rupture occurs that can lead to the hyper inflation of lungs or pneumothorax. That is what is occurred in here. And in secondary spontaneous pneumothorax, there is due to diseased lung, that is increased, example Bulle emphysema as I talked earlier, and Marfan syndrome and infections. And also mechanical ventilation with use of high pressures, that is barotrauma, can occur in secondary spontaneous pneumothorax. In traumatic pneumothorax, there is caused by blunt, that is rib fracture as in road traffic accident, and penetrating as in gunshot injury GSW, or iatrogenic, that is central line placement, lung biopsy, barotrauma due to mechanical ventilation trauma. These are the classic causes we have to remember. Rib fracture causes traumatic pneumothorax. Also, gunshot injury causes traumatic pneumothorax. And in tension pneumothorax, it can be from any of the above, either rib fracture or gunshot or central line placement and biopsy. Air enters pleural space but cannot exit. This is the point in here. This is like one way valve, right? Air is entering, but it cannot come out of the lungs or pleural space. That is why there is tension. Increase in tension means increase in pressure, right? So that is why it is occurring. So in tension pneumothorax, there is increase in intrapleural pressure, and the intrapleural pressure is more than atmospheric pressure. So in X-ray you can see here tracheal deviation is occurring, and there is also collapsed lung. There is the hyperinflation, and in hyperinflation there are more amount of ribs, more than 12 ribs, 10 to 12 ribs are seen in chest X-ray. And also increasing trapped air lead to tension pneumothorax, as I talked earlier, and trachea deviates away from the affected lung, like you can see here. This is deviation away from the affected lung. And then it may lead to increased intrathoracic pressure, that is will cause mediastinal displacement, that is kinking of inferior vena cava, and that will lead to decrease in venous return, that is decrease in cardiac output, and lead to obstructive shock, that is hypotension and tachycardia, also jugular venous distension, and it will need immediate neural decompression and chest tube placement. And actually chest tube placement is under water cell. Chest tube placement is down under water cell. You have to remember this. Water seal, 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 right? So that is how we complete our pneumothorax. Let's go into the pneumonia. Here we will talk about pneumonia now, and natural history of lobar pneumonia, lung abscess, and then lung cancer. That is all for today. And we will finish our respiratory pathology. It is obvious, right? So what is pneumonia? Pneumonia is the inflammation of lung parenchyma actually. So there are types of pneumonia, either lobar pneumonia, bronchopneumonia, or interstitial pneumonia, and also cryptogenic organizing pneumonia, aspiration pneumonia. These are the types of pneumonia, right? So in lobar pneumonia, what actually happens is the causative organs, these all are differentiated by causative organs actually, and also the characteristics. So streptococcus pneumonia is the most common cause of lobar pneumonia, where specific lobes is affected, as in X-ray, either upper lobe or lower lobe or middle lobe. Specific lobe is affected, and the benefit of this is that it is limiting, and we can limit the growth of pneumonia or bacteria by rejecting the lung, that is specific part of lung, right? So Legionella and Klebsiella are also the causes, and the characteristic feature is intraalveolar exudate is there, leading to the consolidation. As we see, these all are intraalveolar exudates, so that is why we are seeing consolidations right here, and it may involve entire lobe or the whole lung. And in bronchopneumonia, what actually happens is acute inflammatory infiltrates from bronchioles into adjacent alveoli occurs. So there is patchy distribution involving greater than one lobe. There is no specific single lobe that is affected because it is diffuse case, and it is also can occur due to Streptococcus pneumonia, Staphylococcus aureus, or Haemophilus influenza, or also Klebsiella. So another is interstitial, that is atypical pneumonia. Atypical pneumonia is termed atypical because it is caused by atypical organisms like Mycoplasma, Chlamydophila pneumonia, Chlamydophila psittaci, and Legionella, Coxiella, Burnetii, viruses like RSV, Rous sarcoma virus, cytomegalovirus, and then influenza and adenovirus. It is called atypical because it is caused by atypical organisms, and there are diffuse patchy inflammation localized to interstitial areas at alveolar valves. Here you can see they are diffused, patchy. They are diffused, patchy inflammations, right? Chest X-ray shows bilateral multifocal opacities, like this opacity, this opacity, this opacity. This is multifocal, and it occurs bilaterally. Here you can see here, these opacities, right? And it generally follows a more indolent course, that is walking pneumonia. There is no any severe or sudden onset of clinical symptoms. That is why it is also called walking pneumonia. This is very high yield. You have to remember that interstitial or atypical pneumonia is also called walking pneumonia because it has indolent course. Another type of pneumonia is cryptogenic organizing pneumonia. So etiology is unknown, and there is the absence of sputum and blood cultures, negative. So that's why there are no bacteria or viruses that is causing this pneumonia, and it often responds to glucocorticoids but not to antibiotics because there are no any bacterial or pathogenic infections in here. So it is also formerly called bronchiolitis obliterans organizing pneumonia, that is BOOP, BOOP, BOOP. Bronchiolitis obliterans organizing pneumonia, it is also called like that previously, and it is non-infectious pneumonia characterized by inflammation of bronchioles and surrounding structure, as I said earlier. And in aspiration pneumonia, there is aspiration of oropharyngeal or gastric contents that will lead to pulmonary infection, right? So risk factors are altered mental status, that is decreased cough reflex or glottic closure, dysphagia, neurologic disorder like in stroke, and invasive tubes like nasogastric tubes, that are risk factors. Aspiration pneumonia, and it presents days after aspiration event is in dependent lung segment, because as soon as aspiration occurs, then there occurs pulmonary infection. It is more common in RLL if sitting up, and RUL if lying down, recumbent due to bronchial anatomy, right? So RLL is right lower lobe, RUL is right upper lobe, and it can progress to abscess because aspiration can get infected, and infected aspiration is called abscess. So in abscess there is pus formation, right? There are different different types of pusses too, and aspiration, the color of pus can be differentiated also. So aspiration or pneumonitis, aspiration chemical pneumonitis presents hours after aspiration event due to gastric acid mediated inflammation, and it presents with infiltrates in lower lobes and resolves with supportive care. So that is called aspiration pneumonitis. That is how we finish the types of pneumonia. Now we'll talk about natural history of pneumonia, lobar pneumonia. It is actually, there are 4 stages. This is congestion, red hepatization, gray hepatization, and resolution. So in the first 1 to 2 days there is congestion. Congestion is what is congestion actually? Congestion is the increase in blood flow, right? Increased blood flow is congestion, and that occurs because there is capillary infiltration. There is increased permeability of capillary due to infection that leads to the leakage of protein-rich fluid, right? So that is why the accumulation of exudate is causing congestion. Let's see, this is congestion. So red purple or partial consolidation of parenchyma is seen, and exudate with mostly bacteria is seen. Exudate with mostly bacteria. And in red hepatization, it occurs 3 to 4 days later infection, and there is red to brown consolidation. So what is hepatization actually? These cells in microscopy look like hepatic lobules. That is why it is called hepatization. Exudate is with fibrin, bacteria, RBCs, WBCs, and it is reversible. And gray hepatization occurs 5 to 7 days later. It is uniformly gray Obviously, the color is specified in its one type, and exudate is full of WBCs, lysed RBCs, because now RBCs are macrophaged, are degraded or splitted into two, and then fibrin. And at plus days, it will lead to resolution, that is enzymatic digestion of exudate by macrophage. This is the figure right here. This is grass, and this is it. In resolution, there is a lot of fibrosis. Can occur. So let's talk about lung abscess. What is lung abscess? Lung abscess is actually a localized collection of pus within parenchyma. Abscess means pus, right? So it is caused by aspiration of oropharyngeal contents, specifically in patients predisposed to loss of consciousness. Example in alcohol overuse and epilepsy or bronchial obstruction. Example in cancer. That is when it occurs. So as lung abscess is a complication of aspiration of oropharyngeal contents. That is why it occurs. So in aspirate, the accumulation of aspirate gets infected, then that causes abscess, exudate formation, and pus formation. There is air fluid levels often seen in chest X-ray. Presence suggests cavitation. If in chest X-ray there is air fluid levels, it suggests cavitations, and it is due to anaerobes like bacteroids, Fusobacterium, Streptococcus, or Staphylococcus aureus. And treatment is antibiotics, drainage, or surgery, obviously. And figure we can see that is lung abscess. It is secondary to aspiration in most often found in right lung, because there is a specific features between right lungs and left lung. Actually, if this is trachea, it deviates into two bronchi, right? It splits into two bronchi, and in right and left bronchi there is a difference. So vibes are always right. Remember like this, W-I. You will remember this. Vibes are always right. So WI is wide, BE is vertical, and S is straight. So right bronchus is usually wide, vertical, and straight. So it is very prone to infection. That is why aspiration is most often found in lungs, in right lung. So its location depends on patient's position during aspiration. Right lower lobe if upright, and right upper lobe if it is recumbent. So if a patient is in upright position, that will cause the aspiration to right lower lobe. That is obviously due to gravitational effect, right? So let's tap into the lung cancer, which is our last topic for today. And lung cancer, it is a leading cause of cancer death. As we talked earlier, this is a leading cause of cancer death, and it presents with cough, hemoptysis, bronchial obstruction, wheezing, that is pneumonic cone lesion on chest X-ray, or non-calcified nodule on CT. There is cough, hemoptysis, bronchial obstruction, wheezing, and pneumonic cone lesion. Remember this. Pneumonic cone lesion on chest X-ray. This is very high yield, or non-calcified nodule on CT. So sites of metastasis from lung cancer is liver, low affective boneheads, and brainiacs. Nice. This is very nice mnemonics. You can remember like this. Love, which is lung cancer. Love affective boneheads and brainiacs. So L for liver, A for adrenals, B for bones, because boneheads, and B for brainiacs. So actually, if it is metastasized to liver, then it presents with symptoms like jaundice and hepatomegaly. And adrenals, bone is pathologic fracture, and in brain there is lung mets, that is brainiacs. So lung affective boneheads and brainiacs, that is the sites of metastasis for lung cancer. And in the lung, metastasis usually multiple lesions are more common than primary neoplasms. In lungs, there are secondary neoplasms, or metastasis is more common than primary neoplasms. This is very, very high yield. You have to remember this, that in lungs there are secondary neoplasms more often than primary neoplasms, and these are often from breast, colon, prostate, and bladder cancer. So sphere of complication. What complications can arise in lung cancer. So there is a sphere of complications. S for superior vena cava or thoracic outlet syndrome. Then P for Pankos tumor, and H for Horner syndrome. Pankos tumor, sphere complications. H for Horner syndrome, E for endocrine, that is paraneoplastic, and R for recurrent laryngeal nerve compression that will lead to hoarseness, and E for effusions that can be pleural or pericardial. So in a case of lung cancer, there is a sphere complication. S for superior vena cava syndrome or thoracic outlet syndrome, P for Pankos tumor, H for Horner syndrome, E for endocrine abnormality or paraneoplastic syndrome, and then R for recurrent laryngeal nerve compression that leads to hoarseness, and E for effusions. So risk factors include tobacco smoking, obviously, and secondhand smoke or passive smoking is also a risk factor. Secondhand smoke is smoke from how do you say, camping or campfire. Smoke from campfire can also be a risk factor, and radiation and also environmental exposures like radon and asbestos. There is risk of mesothelioma, and also lung cancer, other lung cancers like bronchogenic carcinoma. Bronchogenic carcinoma is more often due to asbestos than mesothelioma. So there is also a risk factor family history, and the tumors are squamous and small cell carcinomas are central and often caused by tobacco smoking, whereas hematomas are found incidentally and imaging appearing as well circumscribed mass. So squamous and small cell carcinomas are central, as for central obviously. So there are types of lung cancer as we talked about earlier. There is small cell carcinoma, non-small cell, and then that is it, small cell and non-small cell. In a small cell, we have a small cell or weight cell carcinoma. Non-small cell, there is adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and bronchial carcinoid tumor. Small cell carcinoma, weight cell carcinoma is there actually. So in weight cell carcinoma, the location is central. As we talked earlier, there is squamous and small cell carcinoma are central. Squamous and small cell. S for squamous, S for small cell, S for central, because we replace C with S to remember. So characteristic is that it is undifferentiated, which is very aggressive. Weight cell carcinoma is very aggressive, and it may cause neurologic paraneoplastic syndromes, example Lambert-Eaton syndrome, that's myasthenic syndrome, and also paraneoplastic myelitis, encephalitis, subacute cerebellar degeneration, and endocrine paraneoplastic syndrome. Cushing syndrome, SI-ADH, can also occur. Amplification of MIC oncogenes is common, and it is managed with chemotherapy with or without radiation. Histology shows neoplasm of neuroendocrine Kolchitsky cells or small dark blue cells. So Kolchitsky cell is a feature of a small cell or weight cell carcinoma. We should not ever forget this. So chromogranin A positive, which is a new marker, and the neuron specific enolase is positive, and also synaptophysin is positive. So these chromogranin A and synaptophysin are positive in all neuroendocrine tumors. You have to remember like that. So in figure there is cells. These all are the cells, weight cells. The cells are called Kolchitsky cells, right? So small dark blue cells right here. These cells are Kolchitsky cells. You have to remember like this. And in our non-small cell carcinoma, there is adenocarcinoma, which is a tumor of the gland, and its location is peripheral. And large cell carcinoma is also peripheral. So the most common primary lung cancer is adenocarcinoma. This is also very important. Most common primary lung cancer is adenocarcinoma. It is the most common subtype in people who do not smoke is also adenocarcinoma. It is more common in females than males. Activating mutations include KRAS, EGFR, and ALK associated with hypertrophic osteoarthropathy, that is cloving.